Good to start, sir.
Hello everyone. Very good evening and welcome to the second session of the review for the MCQs for your NEET SS preparation. Today's session will review all the questions for the last test and we'll try to finish them pretty quickly but focusing on the major points. And I promise you we'll finish well in time before the Apple event starts. So don't worry about that. So let's begin. So it's been our first question. So this was the first question. These are you would sometimes feel that some of these questions may not be core critical care, but because you tend to have an overlap with multiple specialities, you will see that some will be core obstetric or core other conditions. So that you'll have to accept and deal with certain questions because that's how unfortunately the formats tend to be. So, which of the first question, which of the following is not a risk factor for preeclampsia? The options were multifetal gestation, B SLE, C was multiparity, and D was for prior abruption. So the answer here was multiparity. So if you look at why this is there, to look at the concerned risk factors, generally we're seeing that nulliparity has a pretty high pooled unadjusted relative risk, around 2.1. Elderlies tend to have it or age more than elderly primary or elderly. So you can combine it as elderly primary or an obese elderly primary. Coming with this, they will have a much higher risk. Multifetal gestation. If it is a multifetal or multiple uh, uh, pregnancies or multiple twin pregnancies or triplets, then you have a higher risk, and you will see that more and more, unfortunately, in terms of patients coming to you with more of in vitro fertilization. So that is where you will see them. History of prior abruption, patients with diabetes, previous history of eclampsia, chronic hypertension, prior stillbirth, chronic kidney diseases, any associations like assisted reproductive technology, we've already mentioned that SLE, and if you have antiphospholipid antibodies, so any autoimmune disease. So any high risk factors where you are seeing that the possible vascularity of a particular situation may get effect of the uterine uh, vessels will get affected. That is one definitely a risk factor, and you will see that generally, if you look into maybe somewhat logically, you will see that if it is a multiparous woman, generally with the same sex partner, assuming they have the same, then you will see that they are exposed to similar antigens. And because the body has already dealt with the clinical, this kind of situation before, and you will see that the vessels develop much better than how it is in a nulliparous women, where it is the first exposure to these antigens and it is in terms of forming these so that is will be a answer. So there is no clear logic in this, but this is how it is. So try to look at this. You read the question like this. If you're not sure, look at the more high risk problems like any abruption, yes, or high risk problem SLE, and you know that of the things, multiparity is comparatively a lesser risk problem or risk in terms of pregnancy, and you know that the multiparous pregnancy tends to be lot more not more less problematic. So that will be your one way to answer if you're not sure what you're looking at. Next is, which of the following investigations can help in diagnosing cortical vein thrombosis? Now, this is an important complication you will see. And the options were CSF culture, lumbar puncture and CSF analysis, X-ray of the head, and MR venography. So the answer is D, that is the MR venography. Now, typically, if you have to dissect this question, even if though you're not sure what it is, a cortical vein thrombosis is a block, is a clot or a thrombus in the cortical veins or the drainage veins of the brain. So in the options, if you have to directly rule it out, you will see that the CSF culture is not going to be a main challenge because it's not going to diagnose a vascular issue. It may tell you about an infective problem, but that will take time. So again, it's out. A lumbar puncture and CSF analysis, again, because it is outside, it is nowhere concerned with the meninges. So again, it will not really help you much. Yes, it may help in other complications, which you may tend to see in obstetrics, but this is not the one you will take. X-ray of the head, again, not a common factor. And again, an exposure to pregnancy. Again, you will have to think whether what are you going to do with it. It's not going to pick up anything for you. And then the last option is mammography, and that is the gold standard anyway for a cortical venous thrombosis. So let's just go through uh, a few of the, just a summary of the cortical vein thrombosis. Let's say any clinical suspicion where you're saying that the patient comes with increasing headache, altered sensorium, sudden change in sensorium, may have sudden episode of seizure. Now, again, sudden episode of seizure in a pregnant woman can correlate to eclampsia, but again, that's not the only diagnosis you need to think of, and you need to always look at alternatives. So, let's say the risk factors which we saw earlier were not matching, and then you did feel that this could be one of the causes, then you need to really look at it. So, again, as we said, always whenever high suspicion, always go for a venous cerebral imaging, always MRI with the T2 imaging and MRV. If not possible, to get a head CT with a CTV. So again, coronary imaging. So again, sorry, cerebral imaging. If that can help, then again these two can be done. But always an MRI would be your best evidence. So if that is there, always look for the causes. The etiological causes can be any secondary infections like otitis, mastocytitis, any infections, dehydrations, head trauma, any stigmatofasciitis syndrome, sarcoids, ulcerative colitis, malignancies, rheumatoid conditions, pregnancies, any exposure, as we spoke about in peripartum, postpartum, like we talk about oral use of oral contraceptive pills, which are a very high risk factors, chemo drugs, uh, unfortunately, like COVID vaccination related thrombosis. Again, these are common problems which we used to see much earlier when the was there, but now comparatively, since the vaccinations also has come down, and I think overall that risk is also kind of reduced, but still persists in quite a few patients. And you will see that again, as with all this, you check all the laboratory tests, you get a hematocrit, you get a complete blood count, renal functions analysis, pregnancy test, prothrombin time, APTT, all assuming their pregnancy is there or not there, they will be on the history. And let's say the evidence of thrombosis are not there as per the imaging, though this is quite a gold standard. You look for alternative causes like any stroke, any idiopathic intracranial hypertension, meningitis, abscess, maybe neoplasms, mitochondrial disorders. But again, if it is meningitis, abscess, generally, or abscess or a mass, you will tend to pick it up on the MRI. Yes, I mean, it is may not be, but you may need support with contrast. But again, the presentation might be a lot different, maybe associated with fever, where of more neck stiffness, and these could be your primary issues. So once it is confirmed, always look for any mass effect or midline shifts of any herniation. So if at all a surgical support is required, you may have to go it earlier. And if not, always keep a neurosurgeon on call because you may need that support. And yes, always initiate parenteral anticoagulation. Obvious preferred is low molecular weight parent because we know comparing to unfractionated and low molecular weight, low molecular weight more sustainable, easier to manage, and has a more clear uh, drug action. So again, once the patient is there, doesn't mean that you just stop and forget about it. Always keep imaging, keep checking, check for once the clinical improvement is seen, then you will have to take it forward in terms of once it is stable, transition to oral anticoagulants with direct oral anticoagulants or warfarins, and depending on how the clinical situation is and based on what we get. Or else you can again always do a repeat imaging to consider whether the progression or if you feel the clinical worsening is there, you may even consider endovascular therapy like thrombectomies. Third, next question was, which is the most important criterion for diagnosis of postmortem metritis? Not a common problem that you will get when you're dealing with these cases, but yes, there is something you will have to keep a watch. So common options were fever, leukocytosis, foul-smelling lochia, and parametrial tenderness. The answer here was fever because any infection, fever is going to be the most common cause. Leukocytosis, if you look at it, again, leukocytosis, it's not specific or to infections, and it can happen to multiple other reasons like any stress, post-operative, you will have it, and postpartum is a stressful situation. You might see a slight raise in the leukocytosis. Pauspiralochia also, it is a criteria. It's not the only reason, and there are a few non-infectious causes which may cause it. And parametrial tenderness. Again, it is one of the criteria, but one of the not the main criteria. The answer here being is fever. Next, amoxicillin clavulanic acid should not be used in management of PPROM, premature rupture of membranes, decrease due to increased risk of what? So the answers were options were IVH, heart defect, oligohydramnios, and necrotizing enterocolitis. The answer here was necrotizing enterocolitis. There is no because most of the problems are seen, especially with the clavulanic acid part of it. So if you are using preventive measures because there is a premature rupture of membranes, then you will need to preterm. Then you will need to protect the fetus and the mothers. You will need some antibiotics. So commonly amoxicillin or erythromycin even may be suggested, or cephalosporins may be taken up. And the rest of the organ, generally, these any more general antibiotics do not cause all these heart defects or oligohydramnias. They are more related to other medications. Next, more clinical question. Second. Yeah. So here it's a 65-year-old man which undergoes an open abdominal aortic aneurysm repair and is transferred to the ICU post-operatively. So he is hemodynamically stable, intubated, and sedated with low-dose propofol. Over the next 12 hours, he is extubated and begins to complain of severe incisional pain, 8 of 10 on the numeric rating scale. He has history of chronic kidney disease and ischemic heart disease. The ICU team considers initiating an analgesic regime. So, which of the following represents the most appropriate cornerstone of a post-operative pain management? Now, if you look at this question, it's a 65-year-old male. He has multiple comorbidities. He has CKD. He has ischemic heart disease, and that could have predisposed him to the open aortic aneurysm, and he has been operated. And again, with this kind of a major surgery, you are expecting a kidney injury, and you will need to be there would be chance of a kidney uh, kidney function may be compromised, and you need to keep a close watch. Now, overnight, luckily, because the surgeon was pretty good, you have hemodynamically patient was hemodynamically stable, patient was intubated and sedated with propofol. Again, clinically, if you notice, if this was on the rounds, you will say that low-dose propofol may not be the only reason. And here again, intraoperative patient may have, during the overnight stay, patient may have had severe pain, but it doesn't mean that the patient just will have the pain just after once you've woken him up. So propofol alone would not be the right answer here, and you may have had to given some sedation, but whatever, and somehow the patient managed, but in the morning he had severe pain. So once you have this pain, that is where your background of the assessment comes in. So options were high dose IV morphine infusion for continuous pain relief, multimodal analgesia with systemic opioids, acetaminophen, and regional techniques wherever feasible. Avoid opioids entirely due to risk of respiratory depression, use only NSAIDs, and use ketamine infusion as first line to avoid opioids and NSAIDs. So any pain control is say post-operatively, always look for the options for multimodal, because that is the strategy in any case that you will be using it, and that is where you will always focus on. So answer here being is multimodal because it makes sense because using a combination of opioids, acetaminophen, and regional techniques. Now, options here which will take away because we took a background history of this situation. High dose IV morphine infusion. Again, patient has a CKD, possibly having some amount of acute kidney injury post-operatively. And morphine is going to get accumulated, and all the metabolites are going to be released from the kidneys. So you are going to have a problem of over all the metabolites getting stuck in the body, and even the metabolites and the drug itself being stuck, or your patient might be highly sedated and cause other secondary problems like, as we discussed before, respiratory depression and the third option, and even ileus and itching, and all these are really bad problems, and it's very difficult to titrate. So an IV infusion would be out of the question. Next, avoid opioids entirely. See, again, due to just for the risk of respiratory depression, if you just avoid opioids is going to be a big blunder. So, and using NSAIDs in this condition with an elderly with a CKD yogurt is going to push the patient into kidney failure. So, avoid that. Maybe use safer or opioids like fentanyl or remifentanil if it's available as infusions, or fentanyl either as patches or infusions and combinations, and that really help. And one clinical tidbit, you will notice that the patients who tend to have severe pain, the fentanyl will first target primarily on the pain, and you will see that the patients, only once the pain starts settling down, do the effects of the severe respiratory depression try to start coming up. So if the patient is having pain, higher doses will still help. And once the patient starts, the pain starts dropping down, that's when need to really monitor for respiratory depression. Option D, ketamine infusion. Yes, it's a very good analgesic. It will help you. It is being more and more used as a sedative and analgesic, but the challenges being ketamine does cause some psychiatric issues, withdrawal symptoms, hallucinations, you will have the dissociative anesthesia feel. So you may have to supplement with some sedatives like propofol and or midazolam to control this. But yes, it is definitely as a therapy and as an infusion for ketamine, especially maybe post-operatively, not so post-op like these cases, but definitely in burns cases and soft tissue cases, it really helps. And especially patients who need regular dressings or debridement, it's a great boon. Next, a 42-year-old man is brought to the ICU with a high velocity road traffic accident with multiple long bone fractures and blunt abdominal trauma. He's hypotensive despite receiving 2 liters of crystalloids and ongoing active bleeding. His BP is 80 by 50, heart rates are 138 per minute, respiratory rates are 30, although it can expect to be much higher. SpO2 92 on oxygen. Initial labs where hemoglobin is low, 6.8, platelets are 65,000, INR is raised, lactate is raised, and the surgical team plans a explorative laparotomy, which it should. Which of the following best represents the cornerstone of a massive transfusion protocol? So now this patient, you are saying that the patient has severe hemorrhagic shock. He is in BP is low. He has lost a lot of blood. Platelets are low. INR is low. You know that he has a lot other components. And again, we have unfortunately, because we have given him a lot of crystalloids, because we know initially again to get, no centers may not have a MTB protocol where you might be able to mobilize blood that quickly. So these are the challenges, and so you have already kind of, because of the high fluids, if you look at the ATLS criteria, try to limit the fluid, or even beyond 1 liter of fluid, you will have to consider start giving blood. So here already given 2 liters of blood, so you are increasing the risk of dilutional uh, thrombocytopenia and coagulopathy. So that's going to be a challenge for you. So again, the options here are either you transfuse only packed RBC until the hemoglobin is more than 10. Uh, Next option, transfusion blood products in a balanced ratio, approximating whole blood, delay blood product transfusion till surgical hemostasis is achieved, or use recombinant factor 7A. Now, looking at the background of the question, once you've seen, now looking at the options becomes more easier. We know the initial challenge is the blood and we need to replace it. So the B option becomes the most likely, where transfuse blood products in a balanced ratio. It makes more sense because you have to approximate the whole blood, and that is the criteria and the justification of all guidelines, let it be the European trauma guidelines, it is with the ATLS, everybody talks about giving in a balanced ratio of 1:1:1, preferably, or else at least 2:1:1, the 2 being the RBC. So again, these are the supports that you will need to, so and somewhat approximate to the normal blood replacement which needs to be done, because you know most of these blood components will be split, and getting whole blood again is not easily is not that possible in most scenarios. So that would be the best answer. How to rule out the other ones? Let's say you want to transfuse only the packed red blood cells until hemoglobin is 10. Again, this patient has a high velocity traffic accident, more in terms of long bone fractures and blunt trauma, and assuming that there is and although not mentioned, we are assuming that the brain is relatively safe. So you know that the targets are too high, and targeting hemoglobin more than 10 will cause more transfusion related problems. And again, to achieve that, it's going to be more and more challenging. See, delay blood transfusion till surgical hemostasis. That is not going to be possible, because once the surgery plans an explorator, you will need further products and you will have to support them early. And it's not just that during surgery, you will have to do it pre-surgery, during surgery, and also post-surgery that you will need to support. Use of recombinant factor 7A as first line. No, it is not the first line and may not be even the second line. You will have to consider it much down the road, and only when you feel that all the regular supports are not working, then you may have to consider it as a factor. So the answer becomes you will go for the answer B. So let's have a quick look at the MTP protocol. So first we need to identify the patients who require. Either we look at the clinical judgment, where patients we have seen who require greater than 3 units of blood in 1 hour, or who have lost more than 50% of blood volume in 3 hours, or you might say more than one volume, uh, one cycle of blood in complete over after in 24 hours. So complete one body volume of blood over 1 hour. So again, these over 1 day. So again, these are also criteria which you will look at. But in this situation, you will always look at the shorter criteria. That is the 3 units of blood in 1 hour, or more than 50% blood volume in 3 hours. And there is again scoring, because all of us like scoring. So one is the ABC score. So that is you looking at the penetrating mechanisms. Either one option is penetrating mechanism, where we have the systolic BP at the ED is less than 90, where you have the heart rate more than 120, or you have a positive ultrasound fast exam. So a lot of times patients will uh, end up with this, and you may have to, this would be a criteria of more than two, then you will see that these patients may need a, or you need to activate the massive transfusion protocol. So what do? You activate it as per your system, as per your wisdom. Again, during this time, you are making sure that avoid hypothermia and use blood warmer and IV fluids for IV fluids and products. So again, hypothermia is a killer, especially in trauma. So you need to make sure temperature is maintained. And again, if the patient fortunately comes to you within 3 hours, and hopefully you will try it, administer tranexamic acid within 10 minutes, or 1 gram over 10 minutes, and then 1 gram as a repeat bolus over 8 hours, or either bolus or as infusion over 8 hours. So you can consider it, but always be guarded that anything beyond 3 hours may not be that helpful, and even at times may cause bigger problems. So try to avoid it. But yes, if there is a risk of fibrinolysis and you need to reduce it, then yes, you will have to consider Tranexa. But if it is beyond 3 hours, be guarded in terms of starting it. Then once you get it, you get the cross-matched blood, and you administer the plasma, platelets, and red blood cells either in 1:1:1, as we spoke about it, or else, if not feasible, you may even do it to 1:1:2. That is the plasma, platelets, and the RBCs. And during this time, it just doesn't mean that plasma and platelets will be enough. You will have to consider giving cryoprecipitate also, either as 10 units directly. Now, this 10 units either works in MTP, or if you think about it again, 10 units is a standard cryo that you may have to give in patients with intracerebral hemorrhage and who's had bled out post thrombolysis. That is for reversal also. It is also 10 units. Or you may have to consider fibrinogen concentrate 4 grams, which could be administered as support. And once you've given it, always keep rechecking. You get the CBP, you get the INR, fibrinogen. You look for the electrolytes, especially calcium and magnesium. You look for the secondary problems like hyperkalemia, hypocalcemia, hypomagnesemia, and replace appropriately. And look for and prioritize additional products based on the clinical situation. So you may have to lead if fibrinogen continues to be low. Then you may have to fibrin concentrate or cypressate will be needed. Platelets, again, try to target it above 50,000, especially if there's an active bleed through the drains and during surgery. And INR also try to target it below 1.8. Can be a suitable target, because again, to reach that lower number is sometimes difficult. So anything below 1.8 would be a reasonable target. And once, always try to look for addressing any further organic loss. It can be some surgical bleed or a vascular injury which may not control. And once the plane wings little better or you're reaching your target, so you may need to disconnect it with transfer protocol, because this is what happens with these products keep coming in batches, and we need to be very cautious in that. Uh, a few studies, just to mention where we are in terms of targeting, because we said in unless it is acute brain injury, we need to be cautious. See, generally the criteria is very simple as far as with trick, TRIS, and all these studies which talk about restrictive transfusion strategies. Even in sepsis, you are saying that the transfusion strategy tends to be restrictive to around 7, and that would be your trigger for giving infusions, for giving blood transfusions. But if you look at brain, where you have seen that there are two studies which came in 2024. If you look at the TRAIN trial, this was a restrictive versus liberal transfusion strategy in acute brain injury. And here they found at the unfavorable outcome after randomization. So they are saying that the restrictive group, unfortunately, and the conclusion was patient with acute brain injury and anemia randomized to liberal transfusion were less likely to have an unfavorable outcome than a to restrictive strategy. So if brain needs blood, and you may have to have a more liberal target that is above around 9 or even 10. So that is where we are looking at. So the higher the target would be better if it is associated with a traumatic brain injury. But then if it is a poly trauma, you need to balance both sides, and always try and do not target 10, but maybe at least 8 to 9 would be a reasonable target at the current juncture. Another trial, again, this was also recently done. This was by the other studies in liberal respiratory strategy. Again, here they targeted primarily between 7, and here they targeted much higher, around 10. And here you could see that the higher targets were responding better. So again, this was the trigger, and again, it correlates with the previous trial. So coming to the next patient, here is a 30-year-old primary gravidite, 35 weeks of gestation, admitted to the ICU with complaints of persistent nausea, vomiting, and abdominal pain for 3 days. She has developed jaundice, confusion, and oliguria. Upon examination, the patient is icteric, drowsy, and exhibits pedal edema. Investigations, high bilirubin 5.2, AST, ALT is raised 180, 160, INR is 2.3, ammonia is raised 80, glucose is low, and creatinine is also raised 2.1. And ultrasound shows a hyperechoic fatty liver with no evidence of biliary obstruction. So what would be the most immediate management? So looking at the picture, third trimester, pregnant lady coming to you with nausea, vomiting, pain, jaundice, multi-organ dysfunctions, and hypoglycemia typically pushes towards a, and with the typical finding of a hyperechoic fatty liver, it goes towards the AFLP or acute fatty liver pregnancy. And the treatment is very straightforward. Management is first, emergency delivery of fetus and supportive management. That is your answer. So you always look for the first option is emergency delivery of the fetus, because that is the fetus is the one which is going to cause the problems for you. So option is very straightforward. Don't you look at the others. It is just emergency delivery of the fetus. That will be the first answer. Next, look at the other options. High dose corticosteroids with plasma exchange. It is not really suggested. May suggest in certain conditions, but definitely not for AFLP. And again, even then, even in the other issues like HELP, it is not going to be that effective, and it is just a last ditch push. Supportive management till spontaneous recovery occurs, that can never happen, and spontaneous recovery definitely doesn't happen, and you will just push the patient uh, to the edge if you're waiting. So again, never work for a spontaneous recovery. We need the emergent delivery of the fetus. And liver transplantation as first line. It is again, liver transplant is cannot be done in this situation. And again, a transplant is only and the patient does not recover, or you have irreversible changes. But that's generally not does happen, and most of the time you will see that the delivery will have the patient recover. So looking at the AFLP, just a quick summary. You look at it, pathophysiology. We did talk about a defect in the fetal free fatty acid metabolism. You will need to intermittent broad fatty acid metabolism will accumulate, fat infiltrates the beta hepatocytes, and you will have a dysfunction. Presentation typically happens in the third trimester. You will see that symptoms are very non-specific: nausea, vomiting, abdominal pain, headache, malaise. You will have symptoms of acute liver failure, and even have multi-organ failure. Findings typically what you see seen as raised AST/ALT more than 5 to 10 times, then upper the normal limits, increase bilirubins, alkaline phosphatase, increase INR, increase creatinines, decrease glucose, a very typical sign, low platelets, low fibrinogen, low antithrombin 3. Ultrasound main very non-specific but can't have brightness or fatty infiltration, and biopsy is usually not needed. Again, differential, as we spoke about, all these overlap again with acute viral hepatitis, preeclampsia or HELP, and intrahepatic cholestasis. But if you look at HELP, generally you will have preeclampsia more generally have more severe hypertension. They will not have severe failure, but they will tend to have coagulopathy and more of severe hemolysis compared to AFLP. And management is critical care support, transport to a patient, immediate delivery, and again monitor complications. So these are the fastest way to understand about AFLP. Then, if you look at the next, if you want AFLP, then the next possible question, at least in obstetrics, comes is we talk about a 28-year-old primary gravida, 33 weeks of gestation, admitted to the ICU with comes right upper quadrant pain, nausea, confusion. Her blood pressure is 170 by 110, heart rate is 118, respiratory rate is 28, oxygen saturation is 91%. She is oliguric with a urine output of 20 ml per hour. Laboratory investigations report hemoglobin is low, platelets are low, AST, ALT are raised, LDH is raised, and even the bilirubin is raised. And peripheral smear showing cystocytes, and ABG shows a PF ratio of 150, which again is not positive. And ultrasound shows a subcapsular hepatic hematoma, free peritoneal fluid. So it all matches the classical symptom of severe preeclampsia with HELP syndrome, that is hemolysis, elevated liver enzymes, and low platelets. So again, with this situation also, the answer is very simple. Once we see these issues, it is always emergent delivery of the child, and always look for that as your first option whenever you see such a clinical question. So the answer is C, emergent cesarean delivery with concurrent surgical management of hepatic rupture. Again, the previous, as we discussed, steroids and spontaneous recovery will not be the answer. Yes, steroids may be considered if you are wondering about lung maturity, it may be given, but it is not the reason to be wait, especially if the clinical condition is deteriorating. Livinate liver transplant, again, out of the question, and magnesium sulfate and all, again, an expected management cannot be done, and you'll have to do a more emergent problem. And yes, magnesium will be required, but it is not your priority right now. The priority would be on emergent delivery. So looking at the liver diseases, since we did cover a few of them, if you just compare them, if you look at the intrahepatic cholestasis, so pregnancy, HELP, and the AFLP, onset trimester usually it tends to be in the second trimester. First trimester, generally you'll see hyperemesis gravidarum as your initial problem with liver diseases. HELP is usually third the trimester or postpartum. Again, AFLP be the same. In ICP, you will see generally a family history coming to play. While it's not much seen in HELP, may be seen in AFLP. Presence of preeclampsia, not so much. HELP, definitely, it is a very correlated factor. AFLP may or may not be. Typical clinical factors in ICP are pruritus, mild jaundice, elevated bile acids, and decrease in vitamin K. Uh, Again, in HELP syndrome, you have already covered it in terms of hemolysis, thrombocytopenia. That was a classic presentation as the previous question. And AFLP we did cover in terms of liver failure with coagulopathy, encephalopathy, hypoglycemia, and DIC. Again, here aminotransferases are elevated. AFLP is much more. Again, all have elevated enzymes. Bilirubin tends to be less than 5, all having similar. Hepatic imaging generally in ICPs tends to be cholestasis tends to be normal, and shows more of normal to mild cholestasis on histology. Here tend to have hepatic infarcts, hematomas, and in HELP, while in AFLP it may be non-specific, or you have a bright liver with fatty infiltration, and you will have macrovascular fat infiltration. And the mortality generally not seen, and but it is more of a clinical issues where it does affect the uh, child, and it may have some preterm issues, but generally it is more symptomatic therapy. And while in HELP and all, it is there is risk of mortality because of the multi-organ involvement in both HELP and AFLP, and we know the treatment is again supportive. And yes, we did miss that question because I couldn't probably could just immediately recover, but yes, recollect. But the answer for your in the defect of the enzyme is the LCHD, or the alpha subunit of the long chain 3 hydroxyacyl CoA dehydrogenase defect. So again, these are things that is also maybe a question. So always keep to remember that. Again, a common, we will see that again the AFLP and HELP will have a overlap with the TTP or uh, or HUS. So again, you need to be really careful, because again, any thrombotic microangiopathy will typically show these symptoms where thrombocytopenia, there is thrombosis, and there is hemolysis happening. So these are the patients you will come with a similar picture. So generally, you will see that the transaminitis is not so much in TTP or HUS. Yet there is much more of hemolysis compared to similar to HELP. Thrombocytopenia, again, it is seen, but it is much more severe, tends to be in HTTP and HUS. Antithrombin deficiencies, FLP and LP, it is generally seen, not so much in TTP. DIC is common in AFLP or ELP, but not so much in TTP or HUS. Hypoglycemia, again, more typical feature of AFLP. Renal insufficiency may be more in AFLP, but generally a high risk factor in TTP. And TTP, you know, the pentad of fever, any creatine, renal dysfunction, altered sensorium, hemolysis, and thrombocytopenia. So all these will have a risk for causing these problems. So you need to be really careful. Looking at the next question, here is a 22-year-old man presents with ED after being ejected from his vehicle following a high-speed motor vehicle collision. Upon arrival, his BP is 85 by 55 with heart rate of 141. Two large bore IV cannulas have been placed in the antecubital veins, and lactated ringers have been started. After 3 liters, you're seeing the BP still low. Which of the following statements is the most appropriate regarding management of a hypotensive trauma patient who fails to respond to initial volume resuscitation? Now, looking at the question, you are seeing that the patient is having severe hemorrhagic shock, because even once the volume is getting replaced, and possibly there might be some active bleed going on. So this is how your initial assessment of this situation would be. So options are essential to wait for fully cross-matched blood transfusions. Whole blood should be started rather than packed red blood cells. Blood transfusion should be given after 4 liters, and type O blood, that is Rh positive, should be transfused. Now, looking at the options, you will have to see which is it is essential to wait for fully cross-matched. Ideally, yes, but in this situation, the patient is worsening, and if it is taking lot more time, you may have to look at an alternate option, but keep that as your initial option. Yes, it does sounds good. Second, whole blood should be used rather than packed red blood cells. Again, availability of whole blood is not possible and is not available. And even if you want to mobilize for it, it takes a lot of time, and that should not be prioritized when giving PRBCs or packed red blood cells. And blood transfusion begin only after 4 liters crystallites. Absolutely no. You have already crossed the 1 to 1.5 liter threshold, and here you already at 3 liters, and still the patient is not improving. So you will have to consider blood now, and there's no point of waiting. So now when you see this, now there's no point of waiting. Then the fourth option becomes much more clearer. That says type O blood, that is Rh positive and should be transfused. So yes, although you might say that the risks are much at times higher, but look as a young male, then you may consider taking it as type Rho positive can be transfused. So you look at it as per the guidelines, they say universal type O should be given immediately and required. And typically, if it is Rh positive, appropriate, reasonably appropriate for men and postmenopausal women, where transfusion is required until we get more specific blood. But if it is O negative, again, it is more reserved for women of childbearing age to prevent aluminization and hemolytic disease. But again, if O negative is available, that would be your first answer. But in this question, if you look at the better options, yes, you need to immediately give the blood, and blood type O for a male patient would be a reasonable way to go about it. Let's say there was no option or they were given alternative, then you may have to, you might still say wait, but you need to mobilize faster. So even the first option may not be the best assessment, but I to look for the next best, because if we continue to wait, we might have lost this patient and even lead to further complications, multi-organ complications. Yeah. So next question, a 26-year-old woman presented with acute shock at 35 weeks of pregnancy with profuse vaginal bleeding. She has suffered 2 previous miscarriages, pulse rate of 110, BP is 110 by 84, no fetal heart sounds, hemoglobin is 9.5, platelets are low 66,000, PT slightly raised at 21, APTT is raised at 52, fibrinogen is severely low at 0.5, and what is the most appropriate next marathon? Now, this is 35 weeks of pregnancy, comes with bleeding, previous history of miscarriages, no fetal heart. So the bleed would have triggered for it. All the history of miscarriages would have added to it. Now, again, we don't know the history, the duration. Possibly if the child there was no fetal heart for much longer time, then the intrauterine death or the fetus may trigger towards the DICs, and that is where we are looking at, where typically you're seeing the fibrinogen being low, the APTT platelets are being low on the lower side, PT, APTT are raised. So again, patient is going towards a lead with possible DIC. So if you are treating DIC, then a treatment you'll have to look for the replacing the products as soon as possible. So here, antithrombin 3 infusion, if you look at the first option, may not be the right way to go. Looking at fibrinogen replacement, yes, it becomes a crad because fibrinogen is very low, and that would be a strong answer. Let's look at the other options. IV heparin, patient's already bleeding, risk of bleeding is worse. Heparin really will not work. There is no signs or history of thrombosis. Platelet transfusion, again, that is an option, but again, it is still, if you let's say the usual target of 50,000, it is above. So it may not be a priority right away at this moment. And the priority is again staring at you with the very low fibrinogen. So answer would be a fibrinogen replacement. And according to fibrinogen, you will replace vulnerable factors, factor 8, factor 9 will also be present in that cryoprecipitate. So looking at the DIC, again, with any DIC, you will always look at the DIC picture. So now, in this patient, you do a risk assessment. Does a patient of underlying disorder known to associate over DIC? Yes, possibly here, because there is intrauterine death that can cause DIC, this postpartum case, and any postpartum complications or peripartum complications can cause DIC. So you will have to look for all the coagulations, global coagulation tests that we have advised. And looking at the scoring, you look at the platelets. If it is more than 1 lakh, it is 0. Less than 1 lakh is 1. Less than 50,000, 2. So here, in the previous cases, the number is 1. Elevate DDAM or FTP, we don't have the numbers, but yes, any moderate increase, strong increase, that has a higher number. Prolonged PT, and you are seeing that the more than, it is around 1, where you have around less than 6 seconds, and you might have a higher scoring. And fibrinogen level, again, we are seeing that it is less than 100. So here it takes 1. So if you add all the complications, it comes to come around 5. So yes, you will have a risk for DIC, and you will have to treat accordingly. And if you look at the transfusion therapy, So again, please note in the DIC score, the APDT is not taken as a value. So again, that is something you need to keep very commonly looking at. So the typical question that tends to be asked, at least in Vivas. So this is again something you need to be looking at. And transfusion therapy, again, the management guidelines are very straightforward. Platelets, if it is more less than 50 to 75,000, generally we take it as 50 years will be a reasonable target. Yes, if it is more of traumatic brain injuries and all, you may have to consider a higher number, but 50,000 is a reasonable target. So platelet concentrates or single donor platelets will be helpful. Fibrinogen, anything less than 1.25 milligrams of deciliter or 1.2 grams, then you need to consider cryo, where you're giving 10 units of cryo should be discussed a bit earlier, and it is continuous. Hematocrit, again, targeting around 7 would be a good number, 7 to 8. If it is brain injury, you will, or active cardiac issue, you may target slightly higher, around 8 to 9. And any PTIN of more than 2 or APTT normal, you will have to consider with FFP. So these are the ways to initial target it. Next question, a 40-year-old man is admitted to ED with involved in the house fire. He is extremely drowsy, but on examination, he seems to be well perfused with cheeks almost pink. A VP is 100 by 60, pulses is 95 regular, blood gas analysis show a carbon monoxide level of 10% and metabolic acidosis of 7.15. So which of the following would be the most, see again, luckily we have blood gas analysis which can show up this, but a lot of times you may not see it and you might see slightly showing as a normal saturation, then that is something you will see. Although, especially when you're putting the pulse oxidation, you will see the saturation tends to be normal. But then these patients have severe metabolic acidosis, pH is severe 7.5. It's from a burning building. He looks well perfused. So typically, that's the skin that you will see a cherry red color. So then you will see that this is the possibly a carbon monoxide poisoning. So any carbon monoxide poisoning, you know, it is you need to displace the carbon monoxide, which is going to be stuck to the oxyhemoglobin, and you will have to displace it as much as possible. So the first and foremost that you can do immediately do is 100% oxygen, and that should be your first answer. That is the 100% oxygen by mask. Other options like hyperbaric can be done, but that becomes second. But not all areas will have immediate access to hyperbaric chambers. So first would be 100% oxygen, and then looking at other options. Looking at other solutions like IV mannitol, sodium bicarbonate may not really help you. Yes, about the acidosis slightly, but again, the acidosis here is due to the severe hypoxia leading to the challenge. So that needs to be targeted earlier. So the management is very straightforward. If you look at the carbon monoxide poisoning, immediate actions, remove the patient from the exposure, ensure a safe and ventilated environment. As always, any criteria, ensure the patient is safe, and also the person who's managing the patient is also safe. So scene safety takes precedence. Oxygen therapy, again, 100% oxygen to given by a non-breather, and hyperbaric therapy to be suggested. Under the support, consider oxygen monitoring, monitor the epoxy hemoglobin levels because we have that support here, and look for any supportive care for cardiovascular and respiratory complications. Look for any, later on, maybe you may have to look for delayed neuropsychiatric sequelae, and follow up in terms of cognitive therapy and reassess for recovery. So these are the main areas. Next question, a 14-year-old bangs his head against an opponent in a football match, and 2 hours later complains of headache, vomitings, and then loses consciousness. His breathing is irregular and the heart rate is 10, and heart rate, respiratory rate is 10, and the heart rate is 40. What is the most likely diagnosis? So here patient has a trauma, there is a collision. Initially he was fine, but then after 2 years, assuming earlier he was fine, but 2 hours later he comes with sudden headache, vomitings, and loses consciousness. So you know it's a very acute brain issue which has occurred, and there are irregular breathing, heart rate going low. There's signs of raised ICP or towards Cushing syndrome. So that is something which is very acute, and you need immediate therapy. So that is where your answers would be. So looking at the options, cerebral contusion generally may not be the problem. Yes, contusion would be a problem here because of the collision, but contusions generally does not cause such a acute issue or a life-threatening issue. Counterclaim memory, again, similar to contusion, it is on the opposite side of the brain, but again, these injuries also may not cause such acute life-threatening challenges. Extradural hematoma, yes, it would be the best answer here because it is you are seeing a possible patient was doing fine and then worsen. So there is a lucid interval coming in, and which is very classical of a extradural hemorrhage. Subdural hematoma, it can be possible, but generally it seems to be much slower, and patients may not, at least with the kind of injury that you're seeing here in terms of football therapy, subdural hematoma tends to be lesser, and usually subdural hematomas tend to be more slower paced, and they'll have a more longer history. So just looking at a quick summary, this is a classic question of the EDH was the SDH. So origin of the bleed, it is the EDH is middle meningeal artery, while SDH is cortical veins. So this artery, the blood flow is much faster, and you will see that patient has a complication much earlier. By cortical veins, it is a more slower bleed, and you will see that that's how you can tend to remember. Cortical veins for SDH is slower, while artery is faster in EDH. Side tends to be more unilateral, where SDH can be unilateral, bilateral. You will see that generally it is unilateral, but at times patients may come with bilateral, especially the elderly. Typically, you will see a lucid interval followed by unconscious, where the patient seems normal, then suddenly has an unconsciousness. SDS tends to be more progressive or chronic in terms of gradual increasing headache, confusion, and altered sensorium. Fracture association, typically EDH you will see associated with fractures or more severe injuries, while SDH tends to be more trivial injuries. Limited, the EDH typically is limited by the cranial sutures, but not limited by the dural folds of venous sinuses. But here it is not limited by the cranial sutures, and typically you will see that it extends to other areas. The typical shape that you will see in EDH is biconvex, uh, or like lens shaped, or here you will see a concave convex, or a crescentic like a banana shape. And in EDH invariably you will need a surgery, while SDH surgery, yes, it is required in terms of midline shifts, but you may still wait and give it even sometimes conservative also tends to help, especially we have seen it in elderly where conservative therapy patients have improved. So a typical example, as per the things we said, subdural hematoma is concavo concept or crescent shape, typically like a banana shape. It is slower due to veins and generally tends to be seen in elderly, alcoholics, or sometimes children who are younger children who have consistent, unfortunately, like battered babies. So they will have these challenges. Epidural hematoma, it tends to have a lucid interval. It is artery based. It is lens shaped or convex shaped, like a lemon at times. Even they compare it to, that's what tends to happen. They compare it to common regular things. So again, it's going to be a single area. It's going to be fast because the artery is involved, and there's a lucid interval. It goes towards a epidural hematoma. Next question. A 30-year-old man came to the OR after sustaining trauma to the whole body. His BP is 90 by 60, respiratory rate is 34, pulse is 130 by 1 minute. Your senior asked to give him Tranexa. So what would be the incorrect statement? So Tranexa in a trauma patient, again, it's a essential aspect, and that should be the first thing that you need to think. So there might be something which we don't do. So again, first question is 1 gram to be given, IV over 10 minutes. That is the initial dose. Yes, that should be given. Next, it should be administered within 12 hours of injury and given only in case of blood penetrating trauma. Here, no, it is not to be given within 12 hours. The answer is within 3 hours, and that is the guideline which it says. And even your study, that is the CRASH 2, did say that giving after 3 hours, they have actually worsened the prognosis and even seen increased mortality if given after 3 hours. Further dose of next dose, further growth of 1 gram over 8 hours. Yes, that is the strategy. 1 gram to be given immediately within 3 hours and to continue the next dose over 8 hours. And treatment to all patients suspect of having an hemorrhage. So again, this, if you look at the trauma guidelines, whether ATLS or European, they say it is given to be given to all patients. It does not discriminate like case of blood penetrating trauma or any other kind. So looking at Tranexa, it is used for multiple areas and not just trauma. Let's look at the cases. Trauma patients, yes, reduces mortality at 28 days, pre-3 hour trauma setting. CRASH 2, we discussed just discussed about it. So 1 gram in 10 minutes and the next 1 gram over 8 hours, or next 1 to 2 grams bolus also may be considered. Obstetric pathology is again a very important factor. It does reduce mortality and postpartum hemorrhage, and again has a pre-3 hour setting, but it can be used later on. Traumatic brain injury, again the CRASH 3 trial, which has its own comment. Will not go too much in detail, but yes, the CRASH 3 trial they did look for it in Tranexa and TBI. So in the guideline, simplest is it is unclear for mild to moderate. It may or may not help in traumatic brain injury, but for severe TBI, you have seen that it is not strongly indicated. So you need to be pretty guarded in terms of using it only for traumatic brain injury. This is a polytrauma. Yes, you will consider going ahead. Schedule surgeries. Yes, it can be used for ortho, gyno, or cardiac surgeries, and may be considered for certain surgery like neurosurgical or urology. It has been used, but it is one place where you are not going to use it at all. It is in GI bleeding, Especially the halted trial did say that it is not to be used and it has shown a negative factor. So again, Tranexa in GI bleeding is not such recommended. And also in spontaneous intracranial hemorrhage or SH, again, Tranexa has not shown a great effect. SH, yes, you may consider it as infusion for initial preventive, but that was in the earlier guidelines, but now it has been slowly removed. And you will have to be very guarded or try to avoid it as much as possible in ICH or an SH. Next options are, like, since we spoke about the crash trials, we'll just talk about the crash 1, crash 2, and crash 3. Crash 1 is the TBI where you're using corticosteroids. Remember, crash 2 and 3 are the Tranexa based therapies, but crash 2 to 3, or if you T based, let's say 2 is the letter is T, and again 3 is also letter is T. So easy to remember, it is the trauma based, while it is the crash 1. Although it is used for traumatic brain injury, it is about using of corticosteroids. So again, here they thought corticosteroids may help in reducing traumatic brain injury, but unfortunately it worsened the risk of death, and that is one of the only level 1 recommendation if you look at the traumatic brain injury guidelines, where they say that do not use this therapy at all. While crash 2, we did just discuss about crash 2 and 3. So we'll just skip this, but you can keep this as a quick reminder in terms of understanding where these situations go. But generally, for present level, they would be primarily talking about crash 2, which is the standard therapy. Next, you're looking at 34-year-old male patient coming to present emergency department after a motor vehicle accident. His BP is 90 by 60. His blood lactate is 3 millimoles per liter. What would the next step? So here BP lactates are a little raised. So BP is reasonably okay. So what will you do? You want early total care, damage control surgery, further blood investigation, or further resuscitation, repeat lactate levels. So here you will early total care would be a good answer, but here since we are looking at the lactates and we don't want that lactate persisting very high, so we will look at that would be our best answer. You do a resuscitation and then repeat the lactates accordingly. Investigations and all, yes, you may consider it, but again, here you know that the patient has BP is little borderline, platelets are high, so you may consider resuscitation and let's look at it. So again, don't keep chasing the lactates. You know the lactates are caused by various causes. So anything you may have to look for an underlying pathology. So either look at either type A or type 1, where you're looking at hypoxia or hypoperfusion, either hypotension, respiratory failure, or any local issues. Or we may have to look for type 2 types, where you're looking at either the organ failures like liver failure, renal failures that is causing it, drug related like metformin, or you may look at other causes like any thiamine deficiencies, nourished alcoholic, malnourished patients, any inborn errors of metabolism, stress like sepsis. Sometimes drugs may cause it because of the increased sympathetic drive. So all these would be causes for increased lactates, and that would be your uh, target to look at. Next, patient Ramirez, 45-year-old male, rushed to the emergency department following a high motor vehicle accident. Restrained driver involved in a collision. The heavy truck upon arrival is unconscious, vitals are unstable, is actively bleeding for multiple lacerations and obvious deformities. A team of trauma surgeons examined and decided to go for damage control surgery, and we need to match the stages. So again, the answer would be, if you look at the options, it's a very straightforward as per the guidelines. So there's no logic here. So the answer is A. That is, you're looking at primarily the stage 1 would be, as with any surgery, first to get the right patients, that is appropriate patient selection. So that would be your first option. Next, look for the control and hemorrhage and control of contamination. So try to stabilize the problem. Next, continue the resuscitation in the ICU. So we are just taking initial control of the bleed and then continue resuscitation. Then you go for a definitive surgery and then abdominal closure. So we look at this situation, so it will be A4, B5, C2, D3, and E1. So that would be your answer where you are looking at that. I think in the question those markings are wrong, but that is where the answer would make sense. So you're always looking at the damage current, identify the right patient, take the appropriate control of hemorrhage, control the contamination, continue resuscitation. It's a stage approach. Basically, you're breaking the surgery into parts. So you're first controlling only the bleed, and then once the resuscitation or patient begin a better stage to go ahead for the surgery where you can tolerate, you go for a more definitive surgery and then closure. Next question. These next two sets of questions are actually a very irritating type of questions which do tend to come up in the exams. There is unfortunately there's no logic and it just you need to mug it up. I would suggest keep these questions or these kind of classifications be ready with you with just before the exam so that you may just run through them and so that you can just use it and then uh, I think generally just forget about it because these are questions which, again, in your clinical practice may not really help you. And these are just an initial assessment or to give you an assessment of the high risk of the hemorrhage that could be occurring. So here the patient admitted as the ED with a road traffic accident. Upon examination, patient appears anxious, confused, pulse rate is 130 per minute, respiratory rate is 30, patient's urine output is low, and you will have to classify the hemorrhagic shock as per this patient. So again, if you look at this criteria, the answer becomes class 3. So how do you fill it up? It's straightforward as per the hemorrhagic shock guidelines. So we'll just run through this. Next question again, base deficit in class 3 shock in an uninjured patient. Again, it is -6 to -10. Again, not very, it's extremely difficult to remember it because the same, at times, even the same classification may not show up the base deficit. So you need to be wary of it and always look for that where the base deficit also kind of guide which will have both. So it's a very straightforward question. Again, the classification has its uh, multiple challenges and there have been multiple critiques on it, but it is still part of your ATLS and you need to have a reasonable idea, especially in terms of simplest ways, in terms of at least remembering the blood volume loss that is less than 15%, 15 to 30, 30 to 40 or more than 40. That would be your best way at least to assess in terms of the how bad the patient has been. Next, looking at the next question, a 40-year-old male, known case of chronic liver disease, sustained trauma to the abdomen. His BP is falling, so you need urgent blood for cross matching and coagulation profile was sent. And luckily, we have an early TEG. If you look at the TEG here, we have given the answer. It's a decreased MA. So if it's a decreased MA, then it's typically you're looking at the platelet transfusion. So the answer is very straightforward. So FFP, Tranexa, and factor VIII may be considered, but here in other situations, but here the MA is your primary. So let's look at it. So there are, or the maximum amplitude. So look at the major options that we look here. There's a quick run through. You can keep this as a quick reference and that will help you really clear faster the exam. So our time, if it is, it's the our time is to start, time to start forming the clot. It is normal is 5 to 10 minutes. Primary looking at the clotting initiation, the coagulation factors are required. So treatment is FFP. K time, it is a time until the cross reaches a fixed strength. It takes on 1 to 3 minutes. But here again, it's the fibrinogen. So you need cryo. Again, the alpha angle also, it is speed of the fibrin accumulation. Again, a typical angle is 53 to 72. And again, it is again in terms of fibrinogen. So again, you need to replace cryo. Maximum amplitude is the vertical amplitude of the tech, usually are 50 to 70. So again, easy to remember. Alpha angle and MA will have a similar numbers, 50 to 70. Platelets, because here you need to stabilize it. The fibrinogen is got, the clot stabilization comes through platelets. So you need platelets or factor VIII. And if times lysis at 30 minutes, so LY 30, that can happen where you're seeing that the amplitude reduction after 30 minutes. So this can normally it is 0 to 8%, but if it is excessive fibrinolysis, then antifibrinolytics like Tranexa or aminocaproic acid will be required. Again, if you look at the TEG waveforms, generally that you see is the normal is this, where it is more sustained, where it's a short R time, good angles, alpha and good K times, and they sustain the MA throughout. While if it is anticoagulants or hemophilia where factor deficiencies are there, you will see that the R and K times are a little prolonged to reach the zygotes and MA angle is reduced. So here you may need to give anticoagulant or FFPs. In terms of platelet blockers, you will see the MA times tends to be reduced. They may have a slightly prolonged K time and MA is reduced. So, but the R time tends to be normal. So again, here you need to have antiplatelets or thrombocytopenia. Fibrinolysis, we did speak about it. The generally the R time tends to be normal, but the MA and all will have continuous decrease. Lysis will be much higher even at 30 or uh, and you will see that you will need to have a thrombolysis. Hypercoagulation, you will say R and K time are decreased, so patient becomes much acutely thrombosed, and the angles, MA angles also tend to be much more steeper. As you can see, it's much more bigger in size. So you will see more hypercoagulation. And in DIC, again, stage one, if it is more hypercoagulable, you will see that initial stage, but generally by the time the patient comes to you, it tends to be hypocoagulable. So you have all these, all things are reduced. Like the R time is rise, K time is low, alpha angle is low, and even the MA is low. So all these will show towards a DIC picture. Next, the Mr. X has undergone laparotomy for intestinal obstruction. Now, post-op day 3, he complains of bilious vomiting and is not passing stools and and having some pain, abdominal pain. On examination, abdomen was found to be distended and sluggish bowel sounds were heard on auscultation. So, what would do the next step for him? So, you are seeing that the patient POD3 typically comes with some vomiting, some gastroparesis, or some obstruction could have occurred, and he has not moved his bowels. So, generally, post-op day 3 without any other major surgical issues tends to be generally tends to be ileus, and we note ileus, they might be patient have sluggish sounds may be heard. So again, if that is ileus, then oral diet cannot be the answer, because bowel sound, just because bowel sound, you will not give the feed. So oral diet as bowel sound will not be the answer. Next, putting Ryle's tubes and enteral feeding, again, not an option, because you have various vomitings, they're not past stools. So again, it may not be the answer. Laparotomy, no. There is no surgical indication here where a laparotomy is required, and it will just worsen the problem, or may not help and just worsen it. So the answer is give IV fluids, give Ryle's tube, and advise immobilization. Yes, and advise mobilization would be our answer, where you need adequate hydration, Ryle's tube to decompress the stomach generally, and help it reduce, and advise mobilization. Yes, use of prokinetics may be helpful. Don't give the feed right away, and you need to wait on it before jumping. And especially in these cases where they have some vomitings and all, always look for the potassium levels and magnesium levels and try to correct them, and try to supranormal correct the potassium, at least in these situations, where keep it around above 4 to 4.5. There you will see that this will help, especially in the movement of the in the peristalsis. So that would be a way to go around this question. Next, Mr. X suffered a car accident led to continuous lacerated wound over his right thigh. And according to the ACS NSQIP classification, what would this wound? So straightforward, it's a continuous lacerated wound. It is a generally a contaminated wound, because it's open, and you will see that these kind of wounds will get eventually contaminated. So the answers would be here it's a definitely an accident fresh wound. So class 1 is a clean wound where uninfected operative wound in which no inflammation is encountered, and the respiratory elementary, genital or urinary tract is not entered. So here that's a typically clean wound. If it's clean contaminated, is an operative wound in which the respiratory, elementary, genital or urinary tracts are entered under controlled conditions and without any contamination. So there are operations involving the biliary tracts, appendix, vagina, oropharynx. So these are clean but contaminated, while the first ones are tend to be more of blunt trauma, abdominal walls. So there they are not exposed to the mucosal area. Contaminated wounds, they are typically open, fresh accidental wounds with major breaks in sterilization technique, or cross pullage of the GI tract in incisions, and that is where you will see a clear accidental wounds that is contaminated. Dirty infected are old traumatic wounds which retained devitalized tissue and those involving existing clinical infection. So if it is beyond this, then it is dirty infected, but generally the confusion happens to clean and contaminated. So if it is an open, fresh, immediate wound, it is contaminated because it is exposed to all the environment pictures, while it is a more an operative wound which is contaminated with the surrounding mucosal areas, rather the oral, gastric, genital or urinary tracts, then it is tend to be clean contaminated. Anything uninfected operative wound is clean. Again, next question. All of the following statements regarding abdominal compartment syndrome, a very important aspect. Here, the patient has surgery related to the retroperitoneum, one of the primary initial causative factors that may lead to abdominal compartment syndrome. Yes, it is a possible problem. ACS manifests as an increasing abdominal distension followed by increased peak airway pressures, oliguria, and anuria. Yes, that's again a typical symptom where increased abdominal hypertension will lead to further organ dysfunctions, typically leading to abdominal distension, increased airway pressures because the abdomen is distended. It will cause a severe atelectasis and increase your peak pressures because the abdomen you are unable to breathe. And oliguria, because again it will have increased abdominal pressure and decreased vascular components will lead to oliguria and anuria. ACS diagnosis requires an intra-abdominal pressure of more than 25. It does sound fine, but let's look at the next question. Treatment of ACS requires opening of the abdominal wall incision and abdominal fascia. So yes, if it is raised abdominal compression, you need to decompress. So that would be your next answer if you are not sure. But if you're coming back to see, it is not just the raised of pressure. It is not 25. It is just 20. Anything rose than 20 with an organ dysfunction, as you're seeing it with the answer in option B, it will lead to an abdominal diagnosis as abdominal compartment syndrome. So abdominal compartment syndrome does not focus on the how high the intra-abdominal hypertension is, on the like anything higher than 20 with having an any organ dysfunction will lead to it. And treatment, yes, of course, one of the treatments is definitely releasing of the abdominal fascia. So looking at the definitions, a quick run through. IAP is the steady state pressure. You will see it is abdominal pressure is MAP minus IAP, as with any other. You will see IAP is expressed in mmHg, and at end expiration, normally IAP is around 5 to 7. Intra-abdominal hypertension may caused either by sustained or repeated pathological elevations, anything more than 12. So IAP more than 12 to 15 is grade 1, 16 to 20 is grade 2, grade 3 is 21 to 25, and grade 4 is more than 25. So ACS is, as we said, anything more than anything beyond grade 2 or grade anything beyond grade 2 or grade 3 plus anything more than 20 IAP or with a pressure pressure less than 60 with the new organ dysfunction or failure. They can be primary or secondary. Primary is a condition of injury. This is with the abdominal pelvic region. While secondary due to this does not originate from it. It can be due to over fluid overload. This could be commonest reason. And recurrent ACS refers to condition where ACS develops following previous surgical or medical treatment, either by primary or secondary. So looking at the IHACS medical therapy algorithm, if you look at it again, you look at the patient, anything IAP more than 12, you are saying to manage it. Once you need to keep measuring this IAP, intra-abdominal pressure, and you need to keep checking. And the basis is very straightforward. Always look at all these factors. Any intra-abdominal contents have to be reduced. Either you put an nasogastric tube, maybe minimize enteral nutrition, any enemas and colonic decompression, all this may be required, or you may even discontinue the nutrition. Next, evacuate the intra-abdominal space, and any occupying lesions, like any lesions or any infusions, you need to reduce it, especially in ascites or hemoperitoneums, you need to drain it. Improve abdominal compliance, any improve abdominal wall compliance. So anything outside the abdomen, like any constrictive dressing, abdominal eschars, you might even consider reverse Trendelenburg position. And even if at times even neuromuscular blockade may be reduced, needed. And very important is fluid administration. Avoid any excessive fluid. Try to keep a negative balance by or even balance by day 3. Resuscitation hypertonic or colloids may need fluid removal and even dialysis ultrafiltration to maintain the fluid or balance. So to avoid any tissue or intestinal edema, you may need these supports and any regional perfusion that may be required. So hemodynamic monitoring and goal-directed therapy may be required. So the process is very straightforward. In the abdomen, within the lumen of the intestine, anything evacuate. Outside the outside in the abdomen, but outside the intestines, anything else, try to evacuate or seduce. In the abdominal wall, try to reduce compliance. Anything restricting from the outside, as any pain. Generally, pain is one of the factors that tends to be missed. And again, any eschars, dressings, all need to be removed. And very, of course, is the fluid administration. So these are the ways you will have to target. So anything, always note ACS is intra-abdominal hypertension or pressures more than 20. That's where you need to go. More than 20 with an organ dysfunction, that is ACS. The rest of it is just targeting the intra-abdominal hypertension or measuring it. All the following surgeries are associated with medium risk of deep vein thrombosis except. So answers would be inguinal hernia repair, maxillofacial surgeries, total hip replacement, splenectomy. Simplest way, highest risk are generally to the lower limbs surgeries. So here the answer is a total hip replacement. Rest of it tends to be lower. So simplest way to understand here is stratification for deep vein thrombosis. Wherever the leg movement is reduced or cannot be moved as much as possible, then it is going to have a highest risk. Simplest way to remember. So highest would be any pelvic elective trauma surgeries, trauma, total knee or hip replacement. Wherever the lower limb where the movement is restricted, that is where you have the highest risk. Medium risk would be abdominal surgeries like inguinal hernia repairs, abdominal surgeries, gynecological, urological surgeries, where limit movement may be restricted but may not be completely immobilized. While low surgeries, where low risk would be neurosurgeries, cardiothoracic surgeries, maxillofacial surgeries. Again, these would be there. Again, high risk at times, even in spine surgeries, you will have to be careful because immobilization is higher. But again, the risk of bleeding is also there. You need to balance both of them before jumping ahead. Next, looking at the following are the true for constituents of a preservative solution used in organ storage. So, except. So, options are organ storage solutions. You would remember them. So, generally tend to be bicarbonate and phosphate are the predominant buffers. Yes, it is a solution which is placed outside the body. So, you need something which can recreate the internal milieu of the body. So if that is a factor that we look at, yes, bicarbonate phosphate can be good buffer. So that could be a strong answer. High potassium and low sodium may not be with all fluids, but let's say if you're looking at the classic University of Wisconsin fluid, yes, it does have high potassium and or the urocolins tend to have the older one, which is not used now. So high potassium, low sodium, which will replicate the intracellular milieu. Yes, it will be a answer. Next, lactobionate and raffinose are osmotically active and semi-permeable. So once you see all these numbers, lactobionate and raffinose, you know it is more towards the University of Wisconsin fluid. Yes, they are osmotically active. They are tend to reduce the cellular edema, but they are impermeable. They are not semi-permeable. They are just impermeable. They are not going to cross. So that's going to be there. And option none of the above cannot be the answer. So here we are talking about primarily the University of Wisconsin fluid. So I look, if you have a quick comparison of these, if you look at the urocolins, the C or the Celsior, typically a Celsior is an extracellular fluid and it is generally used for lung transplantation, at least in our unit here. University of Wisconsin or HTK or the histidine, tryptophan, ketoglutarate infusion, that is tends to be more UW tend to be more intracellular, have more as we spoke about lactobionate and raffinose, while HTK has more of mannitol, it has histidine, tryptophan, and ketoglutarate as your supportive, and HTK is extracellular, replicates extracellular fluid. As you can see here, the potassium sodium is higher than the sodium. Sodium is higher than the potassium. While in the University of Wisconsin, it tends to be the potassium is much higher than the sodium. So that is typically it also intracellular fluid. So that is where quick way to pick it up. And HTK also has the name histidine, tryptophan, ketoglutarate, while University of Wisconsin tends to be have more of the raffinose and lactobionate. And if you look at the buffers again, as we spoke about, it has more of histidine, ketoglutarate. That would be your standard options. And looking at the pH and all, if you see most of the Celsior, University of Wisconsin, or STK or Custodiol, both all have a similar pH as to body. But you see the urocolins, which was the first one made, it is more as a lower, more acidic pH. So it is not much used now, but it was having a more historical used. Yes, again, UW and STK are primarily used in the liver and kidney transplants. More specific to HTK, but UW is used more because it the overall maintenance, especially with high cold uh, ischemia time, then with the UW has a better response compared to STK, while Celsior generally tends to be used more for the lung transplants or heart transplant. But again, for heart and lung, you can use STK also. Uh, patient underwent liver transplantation, was placed on immunosuppression with cyclosporin. So assuming, let's say this patient where this fluid was used has been gone for transplantation, and of course he will be immunosuppressed with cyclosporin, or let's say even generally TAC or tacrolimus would be used. He began to develop deranged renal function 4 months later, after which of the following immunosuppressants are indicated as an alternative to cyclosporin. So liver is having a problem. So here doing a side effect of the drug. So generally cyclosporin and tacrolimus were liver. We are assuming they have not mentioned any other challenge, a drug-related issue. So immunosuppression with cyclosporin drug or tacrolimus generally affects the kidneys. So any TAC or cyclo, the options are out. Next, you need to look for a better immunosuppressant. Azathioprine will not cause a renal issue, but from a generally strong alone, it may not really help in terms of immunosuppressions, and you need to use it in combinations. So the next option would be a mTOR therapy, that is a sirolimus. So that would be the answer. So just a quick run through of the action. So mechanism of action, you will see like polyclonal antibodies are ATG, antithymocyte antiglobulins, monoclonal antibodies like OKT3 or anti-CD3 antibody, almetzumab or rituximab, anti-CD20 or CD52s, or you have other basiliximab, that is anti-CD25 antibodies, calcineurin inhibitors, we did speak about them, that is the cyclosporin and TAC, target of rapamycin inhibitors or mTOR, that is the sirolimus, everolimus, antimetabolites like azathioprine, purine synthesis inhibitors like mycophenolate, mofetil, and the king of all, steroids, which shall be used, and again, at times even IVIG will be required. So looking at the side effects, we did talk about nephrotoxicity as your primary challenges with cyclosporins and tacrolimus. But again, with nephrotoxicity, you will have hepatotoxicity, hypertension, risk of press. These are the common symptoms that you will see in tacrolimus. Glucocorticoids, we know most of the therapies. Sirolimus, generally it is bone marrow suppression, hyperlipidemia, and poor wound healing. So sirolimus, the main challenges come with poor wound healing and hyperlipidemia, which can be managed. But if there's bone marrow suppression, we need to be cautious. Again, bone marrow suppression generally also seen with MMF, and you may have associated hyperkalemia, hypophosphatemia. With antithymocyte diclofenac, again, you will see a leukopenia, thrombocytopenia. And with basiliximab and all, generally the risk tends to be more of rashes, fever, and GI symptoms. So each immunosuppressant has its own classical pictures, but generally you will see that MMF or sirolimus will have more towards the more of bone marrow suppression. Steroids will have all the steroid related problems, while TAC or cyclosporins or cyclorine inhibitors will be more of hypertension towards more neurotoxic or any confusion, seizures, press, nephrotoxicity, and hypertension would be the general picture. I mean, the last, which of the following describes the acute renal allograft dysfunction? Any rise of creatinine more than 10% of baseline, rise of creatinine, serum creatinine more than 20 micromoles per liter, or both A and B, or none of the above. So remember, any acute renal allograft dysfunction, any rise of the creatinine or serum creatinine by percentage, or which is not explained by any other clinical problems like infections, any hypotensions, then you will have to be extremely careful. So a safe answer would be A and B. So that is what your answer would be. So just having a quick look at the times of failure. So hyperacute rejection, it can happen. This happens at times minutes after transplant related to preformed antibodies or ABO incompatibility, and it is rarely seen out due to very sensitive cross-matching tests. So on table, we have people have seen these problems, but generally now it is risk has reduced. Acute rejection, it can happen. This can happen anytime after transplant, either within days or few weeks. Generally done by antibody-mediated rejections, either evidence of circulating and donor-specific alloantibodies and immunological evidence of antibody-mediated injuries to the kidney, like inflammation or peritubular capillaries. Is generally you will see it in upon biopsy, or acute T cell mediated rejections by lymphocytic infiltration of the tubules, interstitium, and penia. So the treatment again in both of them would be different. So with antibiotic therapy, you will try to reduce the antibody loads. You may consider plasmapheresis. You may consider IVIG and other immunosuppressants. While in anti-T cell mediated rejections, you will target more on the anti-thymocyte globulins or ATG therapies, and with some immunosuppressants, and yes, steroids in both will be required. Chronic rejection may happen. This happens after 3 months of transplant, and again, this can be due to antibody or T cell mediated, and sometimes you may have a mixture of acute or a superimposed rejection also can be possible. So that's all for now, guys. I think we have covered quite a few, and we have covered few additional questions along with the topics. So I think that would really help you. And if you can get some screenshots of these pictorial summaries, that will really help you do well in your examinations and revise much faster. And this is my number. So this is my WhatsApp number. So any issues or any questions, you can always share it with me, and we shall try it. I shall try to respond as much as soon as possible. As mentioned, we are all working in professionals, so at times we may delay, but don't worry, we will respond to you as soon as feasible. Yeah. Thank you so much. Any questions or any comments? So I think we are done. So anything, you can always get back to you, and all the best, guys. Continue your preparation, and hope to see all of you as successful critical care physicians. Thank you.